Good morning, everyone, and welcome. I'm Joe Ruffalo. I am the general manager for The Hill, and we're very excited to have you all here, both online and in person, for our very important event today, Mind the Gap, the Cost of Mental Health Disparities. I'd like to thank our sponsors, Otska, for their support of this very important discussion. We're here today to mark Minority Mental Health Awareness Month. Chances are, if you're tuning in, or if you're here in the audience, you already know that 1 in 5 U.S. adults live with mental illness, and access to treatment remains a challenge. This is especially true for lower income individuals and minority populations, exacerbating the economic hardships they already face, making treatment even less likely. A new report from the School of Global Health at Meharry Medical College examines the projected impact on the U.S. economy if mental health inequities are not addressed, and the findings are staggering. We'll dive into them in detail in a few minutes. But first, we'll hear from 2 leading voices in Congress who have been very outspoken on the topic of mental illness, especially as it affects minority groups. And we'll be joined later in the program by other experts, doctors, and mental health advocates to discuss a path forward in closing the gap. Before we get underway, a few housekeeping items. If you're in the audience, please silence your cell phones, but we do encourage you all to join the conversation online. You can follow us on Facebook, X, and Instagram at The Hill Events using the hashtag #TheHillMentalHealth. And with that, I'm delighted to introduce our first guest, Congressman Richie Torres, a Democrat from New York and founder of the Clubhouse Caucus, as well as Congresswoman Lisa McClain of Michigan, co-chair of the Bipartisan Task Force on Mental Health and Substance Use Disorder. They are joined by our very own and very talented Cheyenne Daniels, race and politics reporter at The Hill. Welcome.
Thank you all so much for joining us. Congresswoman, Congressman, thank you both so much for being here. We are about to engage in a very important conversation. Want to start off, you have both been very open about talking about mental health and connecting to a common thread with other members of Congress on this topic. And that's what brought you both here today. So can you both share a little bit about why the conversation around mental health is so important and personal to you?
Yeah, I'll just start with my story. I had a personal event happen in my life, and I think it has to do with mental health. I think it has to do with addiction. I grew up in a small community, Romeo. Everyone was a tight-knit community. I was extremely involved, right? And one of my best friends, her son, passed away. He committed suicide. Now, I don't, the jury's still out. Did he mean to? But it was an opioid overdose. I don't think he woke up one night and took a bunch of pills. I think I think he was suffering for a long time. And I was angry. Like, I was so angry. And then I figured out, but I didn't know who I was angry at, right? I was angry. And then I stopped for a moment, and I think the anger came from, I was angry at myself. I mean, this was a family, this was a child who was at my home for Christmas, for Thanksgiving. And I was so blind to it that I didn't see it, not one indication. I mean, that's on me, right? That's embarrassing. And, there's a lot more to the story. We had the funeral, we had the wake at our house, and one of his best friends, to add insult to injury, it was the third day. Everyone was kind of celebrating life, let's just say that. And here's this young man in the corner bawling his eyes out. And I knew him, his name was Barrick. And I said, Barrick, what's the matter? And he's like, Ricky, the gentleman, the young boy that passed away, he's like, he was my best friend. And I said, okay, well, we'll get through it, I'll get through it. Just completely oblivious. Completely oblivious. Now, if you were to ask me, I was pretty tuned in. Like, I was the mom that was at school, right? I was tuned in. And he started crying, and I mean, he's bawling. And to put things in perspective, he's like 6'7", and he's just bawling his eyes out. And I'm like, what is the matter? Come to find out, he's like, Mama Lisa, he says, I don't have anywhere to go. I said, what do you mean you don't have anywhere to go? His mom's incarcerated, and his dad is a drug addict on the street. There again, I'm like, how do I, this kid is in my home, this child is in my home, right? So, you know, I may have had too much to drink that night or whatever, but I'd said, oh honey, you can come live with me. And the next morning, he woke up and he's like, did you mean that, Mama Lisa? And I said, absolutely. Now, it would have been nice if I told my husband. Right? Because we had 3 other kids in the house. But Barrick's a part of our family, and we are truly blessed to have him. But I think the problem, and I know we don't, this is why I have such a connection, is I was angry. And I could either be angry, which I was, or I could do something about it. So I started the drug court, right? I started talking to the kids, but I think the biggest thing I did was I opened my own eyes. And that's embarrassing to say. I mean, but it's the truth. I think that's the biggest problem in society today is people like me. I mean, really. You know, I got to get the mirror out and I got to look in the mirror. How could these kids and these people be part of my life? And I am so blind. I am so arrogant. I don't even see it. Shame on me. So that's why, I mean, I started the drug court and I'm on this task force and I want to do something about it. Sometimes I don't know what, but I want to do something.
Congresswoman, thank you so much for sharing that. And our hearts go out to you and your family, and you're so wonderful for helping that young man.
We are blessed, and I mean that from the bottom of our heart. I mean, the blessings and the education that Barrick has shared with my kids. I mean, the stuff my kids complain about, I don't need to deal with them. I just tell Barrick, go in and get them. And he gets them.
Congressman, why is this conversation so personal for you, for us to make these changes?
Well, for me, mental health strikes close to home. I have struggled with depression for most of my life. Every morning I take an antidepressant, Wellbutrin XL, 150 milligrams, and I feel no shame in admitting it. I feel like mental health is nothing of which to be ashamed. It enables me to be the best version of myself, a productive public servant. About 15 years ago, I was at the lowest point of my life. I had dropped out of college, found myself struggling with depression, abusing substances. I even attempted suicide and underwent hospitalization for a period of time. And I never thought I would rebuild my life and 7 years later become the youngest elected official in America's largest city, and then 7 years later become a member of the United States Congress. But I can honestly tell you, I would not be alive today, let alone in Congress, were it not for the power of mental health care and the stability it has brought to my life. So, I champion the cause of mental health from a place of lived experience. And, I'm a person of many identities. Right? I'm Black, I'm gay, I'm Latino, I grew up in poverty, I'm from the Bronx. But the one identity that connects to everyone is mental health. It's profoundly universalizing and humanizing. People who have nothing else in common with me can connect deeply to my own struggles with mental health. It's the great equalizer. And, every one of us either has struggled with mental health challenges or we know someone in our lives who has had those struggles. So it should be a natural candidate for bipartisanship in Congress.
I just want to take a moment to thank both members for opening up and being vulnerable with us right now and sharing these personal stories. It's not only brave, but so important for folks to recognize that mental health and struggles with mental health, striving for healthy mental health is something that we have to talk about more. That talking about it more can help to lead to change. Do you find that we are starting to talk about mental health more? Is it becoming less stigmatized? And we'll get into the stigma a little bit later in the discussion, but is there a change happening?
About a year ago, I was one of 4 members of Congress who had an interview with ABC News about mental health, and each of us, we were telling our stories. And I said, look, the fact that you have 4 members of Congress openly telling their stories about mental health is a sign of how far we've come. The fact that it's only 4 out of 535 is a sign that we have a distance to travel. So we're making progress, but the mission is far from accomplished.
Absolutely. Congresswoman, you headlined a mental health event with the Hill last fall. Thank you for joining us again. What progress can you share from the Task Force on Mental Health since you spoke with us in the fall?
Well, I think the biggest progress is, and I give a shout out to David Trone, is he's very involved, and he's the one that got me involved, and we've passed legislation, but I think the biggest advance that we've made is legislation is just a small piece of it. We need resources, and we need a lot of them. Yeah. I mean, quite frankly, and although we've made progress, and I agree with what you said, we've made so much progress, but if here's the starting point and here's where we need to be, we've only moved to about here. There's a long way to go, and yes, it's legislation, but it's education, right? From doing these events and talking to people, the progress that needs to be made is so much greater than the progress that we've made. But again, you have to start somewhere. So the legislation is bipartisan. It is one of the things that we do work. Mental health has no political boundaries. Right? It doesn't care if you have brown hair, blonde hair, if you're African American, it doesn't matter, right? So it's one of the things that I think that can unite us and bring us together. And I think it's something that people truly care about. So we've made progress on the legislation, but it's really minimal. I mean, you just look at my state of Michigan, all the people that have mental health issues, the bulk of them are in prison. That's not where they belong. Right? I go to the healthcare centers in my district, and patients have been in the mental health, they go in for emergency or whatever, and a lot of times those patients are there for 100 days. 100 days because they don't have a bed or they don't have a room for them in a mental health facility. That's a problem. So as much as we can say, oh, we're passing legislation and it's great, it is, but we need to see sweeping changes, actionable changes, right? For you to spend more than 3 days to even get evaluated is unbelievable. If you had cancer or a broken leg, we would be up in arms about that. So we have made progress. I don't want to be a downer, but we have got a lot more progress to make, and it's resources.
Part of those resources also mean resources for access. And Congressman, as you shared today about how medication can help ensure healthy mental health, you've also touched on how access to medication can be a major challenge for many Americans. Can you talk a little bit more about that? And is there anything that legislation can do to help that?
Of course, both legislation and resources. I mean, even though the experience of mental health is universal, the lack of access to mental health care disproportionately affects the lowest income communities of color. There's a severe shortage of psychiatrists and psychologists in our society. Even if you have insurance, you could wait months to see a psychiatrist. There are many, maybe even, I don't know if it's most, but many psychiatrists do not even accept insurance. And so it's just in my own personal life, I began experiencing depression when I was in high school. I went to a chronically under-resourced high school in the Bronx. I was one of 5,000 students. When you're one of 5,000, you can easily disappear as a statistic into the bureaucracy. And look, I had no conception of mental illness when I was in high school. So I had no vocabulary for what I was experiencing. But there were no psychologists in the school. There were no psychiatrists in the school. There might have been a social worker, but I thought, I would only go to my social worker to pick up my report card.
Maybe.
Or my guidance counselor. There was no real guidance or counseling. It was just, here's your report card. Yeah. And so it was a coldly bureaucratic atmosphere. And I had asked myself, if I had gained access to mental health care when I was in high school, then maybe all the tragedies that followed would have been prevented. And so as a congressman, I've secured about $8 million in funding to expand the largest network of school-based mental health centers in the Bronx. Wow. Because I feel, our schools are a natural hub of social services and health services. It's in local parentis. For many people, it's the second home.
Yep, I agree.
A little bit about the personal work both of you have been doing. Congressman, you have established the Clubhouse Caucus. Can you tell us a little bit about that?
Yeah, I'm a strong supporter of the Clubhouse model because of its simplicity. I feel like the starting point should be a recognition that those with mental illness are no different from everyone else. Like those of us who struggle with mental illness, including severe mental illness, have a need for community, a need for love, a need for dignity, a need for a sense of belonging. And I've always felt that community centers, senior centers, and clubhouses, which are specifically designed for those with serious mental illness, that can be an elegant solution to the problem of loneliness. And so I've made it a personal mission of mine to promote the Clubhouse model throughout the country, and it's been a resounding success in the Bronx.
Congresswoman, you are the president of the North End support team in Macomb, just making sure I'm pronouncing that correctly. What's something you have learned, and you've touched a little bit on this in our discussion today, about how drug use, addiction can either impact or be part of mental health?
Well, a lot of the times what I've seen from my experience is it usually starts with people start to self-medicate, right? And the whole reason why we started the drug court in Macomb County was right after the passing is I started listening, right? I started listening. It's all around us. We just don't take the time to listen and to open our eyes to see. We only see what we want to see. So I started seeing what I wanted to see, and there was a real issue in our community with mental health that, listen, I'm not a doctor, I don't play one on TV, but it's common sense. You can see that when I have a mental health issue, I want help. There's no resources there or very limited, and typically the people that need those resources, that mental health resources, don't have the funds, don't have the access to it. So what do? They begin to self-medicate. Then what do? They they do an illegal activity, whether it's the drugs or whether it's stealing money to get the drugs or whatever it may be. And we were incarcerating all of these people. Okay, well then you incarcerate somebody for 30 days to put them in jail, to put them in the same environment with people who are just like them. That didn't help them, that hurt them, right? So what I did with other members of my community is we started a drug court, and we said, hey, listen, if you want to get help, if you want to get clean, we want to help you. We want to help you with your environment. We want to help you with a job. And we want to help you, not persecute you, but to help you get back on track. And if you can make it through the program 18 months sober, clean, whatever word you want to use, then it's not on your record, right? But we help you get jobs, we help you connect with counselors, we help you. It's so much bigger than that. Now, it's not big enough. I mean, we only graduate maybe 18, 20 people a year out of this program, but for our little community, I'm telling you, that makes a difference.
Absolutely. The work that both of you do, I think we can all acknowledge that government and Washington, D.C. in general are stressful, can take a toll. How do you find balance in your own life to help ensure that you are maintaining a healthy mental health?
You know, I probably don't do as good of a job as I should, right? I should work out more, I should eat better, but I think for me, the biggest mental health breakthrough that I had was to get rid of the anger, because you can be angry, and I was for a long, long time, or you can do something about it, right? That's what helps me. The second thing that helps me, to piggyback a little bit on what you said, Congressman, is I surround myself with good people. It is the key to mental health. If you surround I don't have to hide who I am, right? I can have a bad day, right? And I don't know if you've noticed, but people can be kind of mean in politics, right? Especially on that social media. It hurts my feelings. But I think it's the people that you surround yourself. I am blessed to have to be surrounded with people on my staff and in my family that truly care about me and that I can truly be myself.
I feel like I fail at the work-life balance.
Epically.
I do go to the member gym as an outlet. I do try to remain in touch with friends so that I can escape. I have this idea. I feel like the United States should have like a national tradition of Shabbat. What I appreciate most about Shabbat is that you disconnect. You turn off the phone for 24 hours. Not everyone turns on the phone, but imagine just having dinner with your family and disconnecting yourself from the overwhelming onslaught of social media and smartphones and connecting yourself to the things that matter in life, family and friendship. I feel like all of us would benefit. So I feel like there are simple solutions to the problems of mental illness and loneliness and stress and trauma in our society. And obviously, we in government are part of the solution, but there's a human element that can be powerfully transformative.
Yeah.
So in our last minute, then, I'm going to put you both on the spot here. 30 seconds. Speak to that human element. What is your call to action to our audience, both here and watching at home today?
Tell your story. Tell your story so that we can break the silence and shame and stigma that often surrounds the subject of mental health. There is liberation in the act of telling your story, and nowhere more so than on the subject of mental health.
Great. I think for me is lose the judgmental piece. I mean, I take that from myself. So many of us don't understand, so we judge. Lose the judgmental piece. Stop the labeling. I despise the labeling. We're all human. We all have struggles. It's just different varying degrees. The second thing I would say, be aware, open. If you just stop for a moment and stop looking inward and look around you, there are people crying for help every day. We're just so self-absorbed in what we're doing that we don't take a moment to stop and just look at the person next to us and be kind. I mean, it's amazing how a simple hello or a smile or a kind word, we've lost that. Those are the two things. I think one, you got to look inward. I know I did. I know that was a big smack in the face for me. And then just be observant around you and be open and welcoming. And the biggest thing is just be kind.
Congresswoman, Congressman, thank you both so much for joining us today and for sharing your stories. Thank you.
Thanks so much. Don't get that on film. Neither one of us
No.
re-elected. Right.
Please welcome to the stage Daniel Dawes, Founding Dean and SVP at the Meharry School of Global Health at Meharry Medical College and author of the new study, The Projected Costs and Economic Impact of Mental Health Inequities in the United States.
All right, we just heard from some of our elected officials. Very important conversation. Daniel, you are going to be here dropping some statistics, some facts for us. So thank you first and foremost for being here. You are here today with a new report about mental health disparities and the cost that these disparities in treatment and care have on our larger society. So before we get into some of those facts in the report, what led you down this path of research?
Ooh, good question. So this year marks almost 25 years to the date that Dr. David Satcher, for many of you who remember his work, he was the 16th Surgeon General of the United States. He was the first to issue a report, a landmark report, on mental health. And as the pandemic was striking us, it helped us realize that when we dug into the data, going all the way back to the founding of the country, we had never, ever during pandemics or epidemics realized an equitable response. And there were communities who were struggling, right, to attain their full health potential and mitigate the impact of the COVID pandemic or other epidemics in their lives. And we thought, okay, Dr. Satcher, you talked about mental health. We're seeing this coming to the fore, right? And for me, just as you heard, I had personal experiences in my own family that helped me realize we've got to study this. It's an underrated issue in health policy. We understand racial and ethnic health disparities in general with physical health conditions. But do we truly understand how diseases of the brain impact our systemic health? Do we understand how that fleshes out in terms of in economics and national security and the like? And for me, what really motivated me was when I had just come back. I was abroad in a different country, came back into the United States after a 9.5-hour flight. I turned on this phone, and this was probably around 2021. And I'm seeing a bunch of text messages pop up, seeing voicemail messages come up. And one of the voicemail messages caught my attention. It was from a cousin of mine, who I, love dearly, but we don't get to communicate that often. And I listened to the message. And in there, she says, Danny, my family calls me Danny, Danny, the doctor's trying to kill me. The doctor's trying to kill me. I need your help. I need your help. You need to call me back. Please help me, help me, help me. And I thought, who would dare try to kill my cousin? Who wants to kill this cousin? My dear cousin, been like a sister to me. And so I kept calling her number back, but I didn't get a response. Then I called her sister and I said to her sister, is she okay? I'm trying to reach her. What's going on? I can't get any answers. She says, well, Danny, there's something I got to tell you. And I said, what's that? And she said, she's okay. I said, oh, thank God. She's all right. But, and I know that she has had depression, okay? I said, yes, I remember that. She goes, but there's something that we've never told you all. And Mom didn't want the extended family to know. And I said, okay, so what's going on? And she said, she has bipolar disorder. And she's been struggling with this for years and years and years. Mom thought that we could keep it, we could manage it ourselves. We didn't need any external help. And as I was listening to the story, hearing all these things, it made me understand, wow, my poor cousin has been struggling in silence. She struggled with employment. She struggled with raising her children. She just struggled. And there was no one to help her outside of her mom and her sister. And I thought, that is unacceptable. The other story after that now, a few months after that, I was hosting a party at my house for one of my kids. And another beloved aunt says, Danny, can I pull you to the side? I said, sure, what's going on? She said, I need your help. I said, and so anyway, so she says, well, I said, what do you need my help with? She says, your cousin, such and such, has been struggling. I was trying to call him. I know he hasn't told you this yet, but I called and called and called a few weeks ago, and I was so scared. Call it mother's intuition, perhaps, right? But something told me he wasn't right. And she fortunately called a loved one who lived nearby to check on him, went to the apartment, got someone to open the door, and found that he's passed out on his floor. And he had attempted suicide. Because at that point, he had been enduring a job loss. He endured a divorce. He was in a terrible custody fight. All of these coupled, right, coming together, caused him to really go on this downward spiral. And it has been a struggle for him now to keep up because he and his mom did not know how to access the mental health services and the treatments that he needed. In the first instance, they thought they could manage it on their own. They realized as they're getting older, it's much more difficult. In this instance, they just didn't know where to begin. And with all of my policy savvy, with all of the expertise and experience I had, getting down to that level to help them figure out how to maneuver this, helped me realize, my God, what a fragmented system we have, right? And there's so much we need to do to help people navigate our health system more efficiently. So with that, after talking with her, helping them, going through that, I thought, gee, how many times is this happening across the United States? How many people like these cousins of mine are struggling as we become a more racially pluralistic society? I wanted to know what were the past costs, the present and the future costs, right, of these inequities in health. The two folks that I mentioned are African Americans, and I wanted to truly understand if we could get into that data as far down as we could to understand the problem and to then figure out how we can develop actionable, culturally competent solutions to help folks like them. And so that's what motivated me on that path. David Satcher's work telling us that we needed to focus on mental health, push it from the rear of the national consciousness to the front of our national consciousness. And then 15 years prior to his landmark report, a group of folks, Millicent Gorham and others I know were involved in that, worked with Margaret Heckler to develop the Heckler report. And in that report, those health equity champions said it is going to take efforts of monumental proportions to get the level of health with African Americans, Latinos, Asian Americans, Native Americans at the same level as white Americans. Monumental proportions. And yet here we are today, and we're going to unveil those numbers. We have not seen but very little progress in mental health equity.
So with your report then, what was some of the most striking numbers or information that you found?
Sure, well, if we could pull up the first slide, we have a slide to share with you. What we found looking at three segmented population groups, racial and ethnic populations from the white population, Black, Latino, Asian American, and Native American, looking at socioeconomic status as well as age. We then looked at it in terms of 4 buckets, right? We wanted to look at emergency department utilization, what are the costs when we fail to prevent and early intervene. We wanted to look also at the intersectional issues. Again, we have done economic studies looking at only physical health conditions. What does it look like with mental health inequities? And how does it look when you connect these two issues, right? Brain and body to get the full picture. That was the second. We also wanted to understand, in addition to that, the productivity loss. So in the first report that we did, it was published 2 years ago, and again, I want to thank Otsuka and our colleagues at Deloitte Health Equity Institute and, of course, the Meharry School of Global Health. But in there, we looked at productivity loss this time to understand how does this affect us to really engage, right, and to help build our society. So we looked at absenteeism, presenteeism, unemployment, and then lastly, premature death, which was the focus of our first report, looking at death by suicide, looking at death by overdose, drug overdoses, looking at death at mental health, the lack of mental health treatments, right, and what that led to in terms of spiraling with their underlying comorbidity, and so then with those points of view, we then dissected the data, looking at publicly sourced, privately sourced data, and what we found was even more revealing. In the first report, we could only get access to publicly sourced data. In this report, we got access to privately sourced data as well as publicly sourced data, and it helped us, again, connect the dots and figure out what was going on. And so in this one, we found that today, in 2024, we are spending as a nation $477.5 billion with a B. Okay, think about that. We know then that as we are increasingly becoming diverse, and at the rate we are going in terms of this mental health crisis, we know that in 2022, CDC last year highlighted the fact that we had the highest rate of suicide in this country, and that is close to 1941 when we were going through World War II. That again should shake the conscience a little bit. But as we are moving forward, it became very clear that by 2030, we were going to hit that $1 trillion mark, again, owing to just the inequities in mental health status and mental health care treatments. So $1.26 trillion, and when you compound that from 2024 to 2040, when we become a majority minority country, that number is expected to reach $14 trillion with a T. 14 trillion. That's $42,000 for every single individual living in our country.
Wow. That's a salary for some folks.
Oh my God, yes. Absolutely. So for us, let me go back a little bit and I'll share the second slide, please. The reason why we wanted to do this is because of the great work that Daryl Gaskin, Tom Leviste, and others had done in 2009 when we were trying to make the case for health reform, Obamacare, the Affordable Care Act, to include robust health equity provisions. There, Dr. Levis, Dr. Gaskin, and others got together and they crunched the number, again, looking only at physical health conditions, heart disease, diabetes, HIV/AIDS, you name it. And they found that conservatively, we were spending $300 billion. They then did another study with Eliseo Perez-Stable that was published last year. And in that report, they found that the number had increased to $451 billion. Isn't that something? And that's just, again, physical health conditions, racial and ethnic disparities in physical health conditions. So we said, let's build on that great work that they have done, and let's, again, make sure that we are pushing the boundaries and our understanding on these issues. So in 2020, we started working to look at the latest data that we could get our hands on. That was data from 2016 to 2020. Because the reason why we chose that date, we saw an increase in the number of suicides among African American boys, Native American children, and others. We also saw an increase in overdoses among Latino children, which was quite frightening to us. That was very interesting. And so we wanted to understand what is happening there and what is the cost, right? We wanted to look at the number of lives that were lost during that time prematurely. So these are excess deaths in terms of what we were expecting to be for that population group, right? Based on The Economist. So we looked at those data and we found that almost 117,000 people had died prematurely within that time frame. And again, that report did not include the white population, just racial and ethnic minorities. African Americans bore the brunt of that at 56,000 people, 45,000 people for Latinos, and then Native Americans and Asian Americans. So we got an understanding of how many folks had died prematurely. Then we wanted to add that cost, because in this country, what we've recognized, we have never been able to realize, like I said, an equitable response, especially in policy, unless we can demonstrate an investment value to the government. Where the Department of Defense may be the gold standard in technology and investments, public health is 25 years behind that. Mental health is 25 years behind public health in many instances, right? Because of the dearth of investments. We spend only $281 billion for accessing mental health treatments in this country, $281 billion. And yet the global health, the Lancet's Global Health Journal did a study and found that if we invest $1 in just scaling up treatments for anxiety and depression alone, the return on productivity and health and well-being is worth $4. Isn't that something? $4. And yet we only spent $281 billion. So with that said, we found that the cost during that time was $278 billion from the premature deaths that we encountered from those racial and ethnic groups. So with that, looking now into the present and the future, we said, let's project out the costs, because we want to know the projected costs and we want to know and understand the economic impact. And that's where you see the numbers on your screen moving in that direction. So
then when we're thinking about the cost of all of this, is it a simple solution of we just need to invest more, we need to put more money into providing resources, providing services, being able to address the premature deaths? I mean, do we know what the answer is?
So I would say yes. Money is always an issue, as we know, right? Because again, there's a dearth of investments, but it's just more than that. As we highlight in the report, looking at it through a social determinants and political determinants of health lens, what we wanted to understand is what was truly, driving these increases in chronic diseases, right? Both the body and mind moving forward. And of course, stress and trauma are at the root cause of many of these issues and the increases that we see and the disproportionalities that we're seeing among population groups. But again, at our School of Global Health, what we have focused on with political determinants of health is to understand how policy and politics impacts our health. What drives those? Every time that we've been able to advance egalitarian or equity-focused policies, we have seen the health of the entire nation improve. Civil Rights Act is one case, right? In the Civil Rights Act, there was a study that was done by Nancy Krieger and team at Harvard School of Public Health, and they found that from 1965 to 2005, there were 38,600 black infant deaths that were saved because of that law. Wow. The Voting Rights Act, again, another study just published early this year, showed that African American infant mortality rates were decreased by 20% because of the Voting Rights Act. So it's not simply just money, although those investments are absolutely critical, but we have to look at the entire continuum, we have to look at the whole ecosystem, and we need to go not only at the individual level, but also the midstream and that upstream level to address the political determinants of health.
Wow. When you hear the percentages, the number of lives that can be saved and I'm thinking of infants, they haven't done anything.
Exactly.
They're just popping out and crying maybe, but they haven't done anything.
Right.
And their lives are being saved when we're able to look at how these policies are affecting this. So I guess my final question for you then, looking at where we are now, we have these numbers, we know that there are solutions. Is there hope? Can we see this change by 2030, let's say?
Well, there has to be hope, right? We have to do this because when I think about where the world is heading, there was, again, just to put it in a global context, since that's what I've been focusing on, there was one study that was done showing that the cost of our failure as a world to rein in these mental health inequities was $6 trillion by 2030. We wanted to understand what the cost is to the United States. We now understand what that is, so we need to do better. I think it is about making sure that at whatever level we are comfortable, whether it is that interpersonal, that intrapersonal, the institutional, or even the structural level, we all have a role to play in addressing these inequities. We all have to understand how the levers of policies have been used to either hinder or advance mental health equity in this country. And again, I would implore folks to look at it from the workforce all the way to the interventions. We know that there is a great need for interventions, but we need a whole of society, a whole of government, society, philanthropy to come together to meaningfully address these problems. Because if we don't, we'll continue to just merely nibble at the edges of the problem like we have in the past. So that would be my admonition.
Wow. Daniel, thank you so much for bringing these statistics and visual of what we are spending and all of this. Thank you so much for your expertise. Thank you, Daniel.
Thank you, everyone.
We've now come to the sponsor perspective portion of our program. Please welcome to the stage Caroline Fisher O'Neill, Director of Alliance Development, Government Affairs, and Public Policy at Otsuka America Pharmaceutical, and Griselda Butler, Director of Independent Medical Education and External Relations with Otsuka Pharmaceutical Development and Commercialization.
Good morning, everyone. It's a pleasure to be here with you today. It's a pleasure to be here during the Bebe Moore Campbell National Minority Mental Health Awareness Month. And it's really an honor to be a part of this conversation around mental health inequities as experienced among minority populations here in the United States. We feel that it's a privilege to sponsor these types of conversations and bring research such as Daniel Dawes just reviewed for you to the forefront. Otsuka is a global leader in the challenging field of mental health, treatment for mental health, mental illness, as well as brain disease, and is dedicated to bringing new treatments and programs to affect positive change for better health worldwide. We have a deep respect for the value of every mind and feel very strongly that effective treatment for mental health is what we need to be focused on with the same sense of urgency and priority as other chronic conditions. So I'm joined this morning by my colleague, Griselda Butler. Good morning, Griselda.
Good morning, Caroline.
Griselda is also a co-lead for our B1 Employee Resource Group. B1 stands for the Black Employee Otsuka Network for Engagement. And Griselda, we are happy to have you here today as well, and excited to hear a little more about you and your work with B1.
Absolutely, thank you. Thank you for having me. When I think about the work that we're doing with B1, something that comes to mind is again, the privilege you spoke of being able to do this work at OTSCA, to work for an organization that has a deep commitment to the value of every mind. I personally grew up in a very civic-minded household. We understood from a very early age the impact that policy has on our lives at every level of government every day. And today my role at OTSCA is really about an opportunity to continue to do the work of educating and informing both internally and externally around the issues of mental health and the impact that mental health inequities have with the disproportionately affecting minoritized and underrepresented communities. Certain health policies really can have that deleterious impact. And I think I'm most excited by the fact that we use data to inform and help us make important decisions around these topics. So yeah, that meaningful component is something that continues to resonate through the work that we do, and I'm privileged to continue to do it. With regard to B1, one of the opportunities that I've had with B1 is to continue that education and information both internally and externally. We understood from the very beginning of the inception of B1 that part of our role is really to bring the important topics that OTSCA focuses on, not only to our OTSCA colleagues, but externally make our impact through our own networks. And one of the ways in which B1 has been able to do that has been through some of the work that we're doing, particularly Black History Month and this month in mental health, Minority Mental Health Awareness Month. And one of the opportunities that we had was to invite Daniel Dawes to speak to our organization to help us better understand the historical context associated with mental health inequities. And through that invitation, we were able to have Daniel come and speak when he was at the Satcher Health Leadership Institute at the time. And that meeting led to this very opportune relationship that exists with OTSCA now. And we are excited as an employee resource group to actually be a part of that, to have been a part of the fruition of that really exciting partnership and collaboration.
I couldn't agree more. It's incredibly inspiring to see what the collaboration between organizations like OTSCA and Meharry can bring forward in terms of solutions for our mental health care system. We do have a very complex mental health care system, and many people, whether or not they're living with a mental illness, feel that we are facing an ongoing mental health crisis. The statistics bear that out. If you look at Mental Health America issues an annual report, the state of mental health in America, and these are statistics that I know most of the people in the room already know, but it's worth repeating over and over again. Over 20% of Americans are living with a mental illness. That's 1 in 5 adults, and that comes out to be over 50 million individuals in America living with a mental illness. Now, furthermore, over half of that population of individuals has not received treatment for their mental illness. So that's over 28 million people not receiving treatment. And I think it's important to think about and ask the question, how many other conditions can you imagine 28 million people not receiving treatment for, let's say, a broken limb or cardiovascular disease? Congresswoman McClain mentioned something similar earlier. But there is hope. We are seeing changes. We're seeing more integration of the needs of health equity in conversations. We're seeing that with state and federal lawmakers and federal agencies. We are happy to see changes that CMS has made, small steps forward. But we really feel that there's so much more that needs to be done. And considering how deeply rooted the systemic inequities are in our healthcare system.
And Caroline, that's again more staggering data, but it is exciting to learn that there are some policy work that's being done, some momentum in that area. There's also some data showing that among those who live with mental illness, particularly non-Hispanic whites, adults are 52% more likely to receive treatment. There's also some additional data that 25% of Asian Americans compared to whites are likely to receive treatment. And that number increases slightly with Hispanic and Latino populations and Black and African American populations. But still, it's not at parity, which I think is really interesting. And it's so important to develop solutions for minority populations who are living with mental illness. And we understand that there are already significant barriers to appropriate treatment and resources. I want to share some additional data if I could. For example, as you said, nearly half of the US population lives, 47% lives in a mental health workforce shortage area, making lack of access one of the most significant barriers to treatment. And for every 350 individuals, there is only one mental health provider. In rural areas, also particularly difficult to access a mental health provider. And then, of course, there's things like stigma, and stigma about a particular illness, which may prevent those from actually seeking the help that they need. But we also want to appreciate the progress that's being made, particularly around CMS and others that are exploring additional ways to include more community-based services, like peer support into their integrated care models. It's a critical tool to help bridge that workforce gap and address related issues, and really to support individuals with lived experience and their care team to ensure that they have access to those additional resources. So despite those aforementioned barriers that we talked about, we know there's important work happening, and we're excited to be a part of it to help address the inequities in mental health that disproportionately impact minoritized populations. Do you want to share some additional examples, Caroline?
Yes, thank you, Griselda. I did want to highlight a couple of excellent examples that some of our partners are doing to tackle pervasive inequities. One I wanted to mention is NAMI's Community Health Equity Alliance. It's an initiative that prioritizes community-informed solutions that address serious mental illness care at the state and local levels in select geographies. So the Alliance is bringing together thought leaders in the areas of mental health advocacy, faith, civic, and healthcare professional services, and the aim is to improve trusted delivery and pursuit of equitable mental health care for Black and African ancestry adults in the United States. The second one I wanted to mention is Mental Health America's Equity Impact Zone project, which addresses inequities specific to different communities, again at the local level, and they are running a pilot program with a community in New Jersey that will directly support those with lived experience to address social drivers of health inequities that are specific to that community, and that will expand into 5 other communities in the coming years. And then lastly, I wanted to highlight what the Depression and Bipolar Support Alliance's work on addressing mental health inequities through their Black support groups. And they've got great statistics that came out of their 2023 data showing participants in these groups reported a 45% increase in their sense of community and belonging. 60% of the members felt a reduction in stigma associated with seeking mental health support, and 70% of participants stated that they received valuable information and referrals they otherwise would not have had. I think this data is really compelling, and it underscores the importance of the initiatives that promote equity by providing the essential emotional support, reducing stigma, and bridging gaps in care for Black communities.
I'm so excited to hear about those programs. It's really important to understand that there's real intentionality behind a lot of these community-based and national programs, and that's exciting to see the progress that's being made. As we have listened to the data and we're absorbing what this means and the impact of the work that's already happening and the work that sort of needs to continue to happen, one of the things I think about is I'm still emboldened to continue what I do. I feel even more emboldened because when I'm data informed, I feel like I can take action on things. And I'm emboldened to continue not only to do my work as a health educator, to continue to provide access to information and knowledge and the data, because knowledge and data are power, and they're actionable things that we can do. I'm also excited to continue the work with B1 to continue to bring these opportunities and these topics to both Oaxaca people as well as externally. and to collaborate and continue to partner with great partners like Daniel and other organizations. And really thrilled to be with you having this conversation today and to continue the conversation and to see so many folks who are very engaged and interested in this topic.
Thank you, Griselda. And I'll just wrap up very quickly and say that the burden of mental health inequities falls upon the shoulders of all of us. We feel that it's important to bring these dialogues and conversations to the forefront to continue to find solutions. We're happy and excited to be able to do that. And we have an incredible opportunity to collaborate to create a more equitable, person-centered healthcare system. Lastly, I just want to say thank you all so much for being here today. Thank you.
Thanks again to OTSCA for their support of today's program. Now please welcome back Cheyenne M. Daniels, joined by our panel of experts, Dr. Gary Puckrin, President and CEO of the National Minority Quality Forum, Daniel Gillison, CEO of the National Alliance on Mental Health, Dr. Patrice Harris, co-founder and CEO of eMed and former president of the American Medical Association, and Chris DeCou, head of global behavioral health at Amazon.
Thank you all so much for joining us for what is sure to be a very stimulating panel discussion. Before we hop too far in, we have talked a lot today about barriers, and we've talked about access, we've talked about resources, but I want to take a moment to dive a little bit deeper into what we mean when we say those words. So Dr. Harris, I would love to start with you, and just if you can give us a little bit of an overview of what barriers are preventing minority and ethnic groups from accessing treatment.
Well, thank you and good morning, everyone. And I will start with saying there are many, because as we look to solutions and we look to identify the barriers, we have to make sure that just as Dr. Dawes demonstrated today, we have to disaggregate the data. And so for different parts of our population, there will be different barriers. But there are some that are overarching. It's access. We've talked about workforce. We've talked about the need for payment and reimbursement forms. Sometimes cost is a barrier. I will tell you, sometimes stigma is a barrier. And some folks are still sort of holding on to, I've got to hold it together. I've got to be everything to everyone. And if I ask for help, particularly around my mental health, it means I'm a failure, or perhaps I'm not praying hard enough. So stigma is a barrier, cost, access. Sometimes the system is a barrier. And that's one of the things I always say is we have to make the right thing to do, the easy thing to do. So where do I start? Who should I call? And then there is perhaps, if you drill it down a little bit more, the desire, an appropriate desire to make sure that the person that I'm asking for help understands me. And we use different terms, culturally relevant, culturally competent. But what people want, and in my experience as a psychiatrist, my patients want to know that I understand them, right? Even though I might not have lived the life that they lived, it is incumbent upon me to make sure that I educate myself and try to understand them. So it's trying to find a doctor, a therapist, a psychologist that understands them. So those are just a few of the barriers that people are seeking.
But when we talk about particularly getting help from a professional, a therapist, a psychiatrist, Daniel, I know that you have pointed out that there are not enough psychologists that treat undertreated sectors. So where do we begin, or how do we begin to address that?
So let's just say this, and I wish, and I'll just start with the fantasy, I wish I could, wave a magic wand today and there would be enough therapists, but there are not going to be enough therapists, psychologists, psychiatrists in the next several years, because the good news is it does take time to train. We do want the people that provide care to provide quality care. So it did take a while for me to go to medical school and finish my residency and train as other mental health professionals do. But what we can do is think about, and something that I believe Dr. Dawes mentioned, integrated care. We do have more primary care physicians, although we have to say there's a shortage there. We worry there. But we need to look at new ways of offering care. So that's integrated care, collaborative care, where you go to your primary care office and they have a collaborative arrangement. And by the way, this is formal. This is not just, oh, I think I'll do this way. And the data does show that collaborative care works. But they have a formal relationship with a mental health provider and can answer those questions and address issues right then and there. Because heretofore, and it still happens, if someone were to say to their primary care physician, I really think I need to see someone, or I'm having thoughts of no longer wanting to live, the primary care physician then was scrambling to try to find someone. And then oftentimes, and unfortunately, it's like, here's Dr. Harris's number. You can give her a call, but then they would call me and find that I don't have an opening for 3 months. And so new ways of delivering care, collaborative care, team-based care, having the team of the doctor, the nurse, the social worker, the at bachelor's level, the community care navigator. And so I think there's opportunities for new team members to enter the market. So we need to think innovatively about how we offer care to expand the resources that we have while we are investing. This is another investment we need to make in the next generation of mental health professionals.
So as we look towards some of our organizations that are available out there, how is NAMI trying to tackle or take this issue head on?
Well, Cheyenne, thank you. And just building on what Dr. Harris said, but first of all, I just want to say thank you to Otsuka for this, hosting this, because it's about us having these conversations. It's about us demystifying mental health. This is very important. And Dr. Dawes, thank you for your work. As I'm a student of your work, I've read both reports, the first and the second, and this information is very compelling. Who is NAMI and what is NAMI doing to address this? Who is NAMI first of all, I came to this work as a father, as an uncle, and as a son. And that's important to this work because it's just like all of you all in this audience. People don't care how much you know until they know how much you care. And all of us in here care. That's who NAMI is. We're an organization that started in 1979. We're 45 years young. We were started by parents, and it was to advocate for our young people who were navigating serious mental illness. We are in over 650 communities across the U.S. in 49 states. We like to say we're the DNA in communities across the country, and we do the work at the grassroots level because we're the largest grassroots organization. We took what I say is our pain becomes our purpose, and that's our passion. In terms of the tangible piece of answering your question, what we're doing is we have something called the Community Health Equity Alliance. You've been hearing about community and the importance of community. So we have this Community Health Equity Alliance that we're doing in over 12 states, and we beta tested it first, so we wanted to make sure we got good data from it, and now we're doing it in multiple states where we're actually working in communities, addressing how do you bring the community to the table to talk about mental health, to find the providers, to help them understand how to navigate their health, and actually create a care journey. So it's also working with the trusted partners in the community. So when we reach into these communities with the Community Health Equity Alliance, we're working with the trusted community leaders. So we're talking about the faith-based leaders. We're talking about the educational leaders that live in the community. We're talking about the care providers that are leaders in the community. So we try to bring them all together to construct a team that the community knows about that can access the care. So, and we also have created a campaign built out of that called Crisis Can't Wait. And we believe there's a crisis right now that can't wait. And if I can give some numbers, rates of suicide deaths among black men have increased by 25% over the last 2 decades. Suicide attempts rose by 73% over the last 2 decades. 73% over the last 2 decades for black adolescents. While injury by attempt of passing by suicide rates increased by over 122%. Now, closing out this statement in terms of as I opened up, not as the CEO of NAMI, but as a parent and as a son and a father, about maybe 10 to 15 minutes from here, my contemporary lost her life to suicide in 1986. And as Dr. Harris mentioned, stigma, it's 2024. My family has still not really talked about it. And the ripple effect is what we try to navigate at NAMI in terms of helping other families before they get to that point.
Yes. Thank you so much for opening up about that and sharing that connection. And I think when we hear those numbers are staggering. And I think they kind of give us a little bit of a gut check about where we are right now. And so, Dr. Puckern, I want to ask you where the National Minority Equality Forum is most focused on right now when we think about those numbers, when we think about the crisis that we're facing, and especially when we're hearing about the crisis that Black men and Black Americans are facing.
So first I want to join in thanking Osuka for putting this event together, and I thank you for the invitation, and always love to come and listen to Daniel. He does fabulous work and really opens the door. And most importantly, he talks about the money. And that's what I want to do. I want to talk about the money, right? So let's have a conversation about the money. We spend $3.4 trillion a year on healthcare in America. By 2030, it's projected to be $6 trillion. There are countries with economies much smaller than that. But what's really important, it comes from every American household. If you look at your pay stub, you're contributing to that $3.4 trillion, and people pretend like it's not your money. It is indeed your money, and you have to ask deep questions about what is happening to my money. And that's where NMQF is focused on. Because when you look at the money, right, so government health insurance, Medicare and Medicaid, is 50% of African Americans and Hispanics are getting their health insurance through the Medicare and Medicaid program. 104 million Americans are Medicaid eligible. That tells you something about poverty in America. 104 million Americans, 1/3 of the US population is Medicaid eligible. And what's happening in those programs, I'm going to use the word, they are rationing. That's why you see the inequities in the program. That's why psychiatrists don't get paid. That's why we have the underemployment that we need in terms of psychiatrists and the psychologists to treat, because we've decided that some people ought not to get quality care. I'm going to be very blunt about it. A decision is made. The American healthcare system as it's currently structured was formed during the era of segregation, when it was okay to have inequities in the system, and those inequities are still there. Come 2025, Medicare and Medicaid will be 50 years old. I think it's time for a reassessment. I think it's time to open the door and say, is that the program as it's currently structured that is going to take us into 2050? And Daniel said something really important to you that I want you to understand, the demographic shift, because the people who we have been rationing most to are the people who are going to be the majority come 2050. And we cannot have that provisioning of health care that we currently have going into that future. So the conversation is really about the money. So Daniel threw out a number. I was trying to do the math in my head, $281 million for mental health therapy out of $3.4 trillion? Out of $3.4 trillion? There's something amiss here that we ought to have a conversation about. And so as we move towards 2025, the National Minority Equality Forum, we're saying, okay, it's time for the family to get together and have a conversation about the money. Right? We want to have a family conversation about the money because we want to make sure that every American who comes through the healthcare door, no matter what the problem is, no matter who their color is, that they get appropriate health care, and we have to end the rationing that's going on in our system. So that's where NMQF is focused.
Absolutely. As part of that, you know, Chris, I want to bring you into this conversation because you're here to help give an employer perspective. And so listening to what many of our esteemed panelists have just touched on, how do you ensure all Amazon workers have access to mental health resources?
Well, first things first, I think I could have this conversation for the next 7.5 hours because already we've put so many important topics and amazing discussions on the table. Everything from how Dan is calling out the role of community and peer support for families. Early in my career, I was deeply influenced by Joseph Gahn, Dr. Joe Gahn, who is big in the world of culturally resonant care. And one thing he's highlighted, and I'm going to geek out for just a minute, and then I'll get back to the question, is we do really good on scientific, secular, and logical in the world of clinical science, but we sometimes jump right past the relational and the sacred. And so when I think about what NAMI does and the way that NAMI has families who come alongside other families as trusted guides, that's like relational and sacred in a way that I'm just so proud we're partnered up on that and connecting Amazonians with that resource with some of the work we're doing. And love the call outs for collaborative care, because it's not just we collaborate and we care. It is a name brand, evidence-based approach that weaves together population health, treatment to target, integrated behavioral health care, co-located, all the goodness. And so anyway, thank you for letting me nerd out for just a minute. But to the core of your point, and I'm touching a little bit on those pieces, is so Amazon has a huge workforce, over 1 million folks in the US plus their families, 1.6 or so million globally. And my team ensures that all of them have access to timely, evidence-based, and customer-obsessed mental health benefits. And so the way we do that is a number of different things. So one is offering a range of different benefits options. So stigma has been one of the things that's been raised several times throughout our discussions today, throughout this event today. And so we build that range of options. So if you are not ready to talk to someone on the phone or have a conversation, we have digital therapeutics, so you can get started on your own. And then those are seamlessly integrated with things like our 24/7 mental health clinician support in the EAP, links to other resources, either kind of baseline counseling through the EAP, baseline pediatric support for all Amazonians for their children and adolescents, as well as all of our health plan programs, and all of that available from that, from day one, from the first day of employment, and the same benefits for every Amazon employee, which we're really proud to have day one and egalitarian benefits. And then just a couple points right from Dr. Dawes, the report that Dr. Dawes shared with us that are called out. We are incredibly serious about integrated behavioral health care, and not just serious about the intention that it should exist. We dive into the evidence base. We dive into the mechanisms. We want to know how you're hitting the core pillars. And that's not just because I used to be on faculty at the Ames Center. We deeply care about making sure evidence-based practice comes to life in the real world via our benefits programs. And then the other call out that was in the report that we've all read in advance of this event was employers supporting culturally informed care. I've mentioned Dr. Joe Gahn, other influence on me and my work as a psychologist. But really at the core of that is we want to, we all share the good intention of culturally resonant care, care where a provider and a client or patient share the same understanding of what causes, prevents, and contributes to healing from whatever the health condition is. In this case, we're focused on mental health conditions. We all want that. We all intend for that. We've tried to take it that next step to build out some mechanisms with our different vendor partners. So our pediatric mental health provider, Brightline, our digital therapeutic provider, Twill, they work with Violet to make sure we have measurements that feed into this that we can track along with it. And we're just constantly scanning the horizon for what are the mechanisms, so the reliable processes we can employ to make sure that we go beyond the good intention of culturally resonant care, but actually delivering it in the real world in a way that's going to work for our very large and very diverse population, because we cannot help but to run into some of the challenges that we're discussing today when we're talking about 1 million people all across the United States.
Right. Dr. Harris, what Chris just gave us was how we can help workers, ways that we are seeing this in practice, but you've specialized in pediatric psychiatry. And so I have to ask you, thinking back to the conversation that we had at the top of this morning with our Congress members, and thinking about Congressman Torres talking about how he wondered if he had gotten help earlier, if things could have been different. Are we providing for our children, for teenagers? I'm thinking in this case, when we're thinking of racial disparities, especially for our Black and brown children.
So many nuggets this morning, and I was so glad, first of all, that he shared his story. I was thinking about the year, it's been a while ago, that I completed my residency at Emory, and we were not talking openly about these issues. People were afraid and ashamed, and so progress, not victory, but progress on that. And of course, as a child psychiatrist, I believe in, as a child psychiatrist and a former public health official, I believe in the public health approach to the mental health crisis that we are experiencing. And by that I mean, in public health, first of all, you have a good data infrastructure. You collect data early and often, and as Daniel just reminds us, that data has to be disaggregated. And we have to start with a whole of society approach, as Daniel mentioned. And so the school system is definitely a part of that, because we know that children, I've seen this in my practice, children and adolescents are reporting more symptoms. Now, by the way, and this gets to further nuance, that doesn't mean that they have diagnosable disorders, but they are experiencing more episodes of anxiety and depression, and so we have to call that out as well. And then what do they do with it? What opportunity do they have to discuss that? And I am a believer, and I know many others are, that the school system is a great place to start. Now, that being said, and my mother was an educator, we have to make sure that the school system has resources. We can't just dump something else onto our school systems, right? We found out during COVID that our school systems were doing a whole lot more than we probably thought they were doing. So, but I think that is a great opportunity, and I appreciate his investment there, making sure there are services in the schools, and that could be mobile, but I think that's a great place to start. And then we can also think about health promotion. You know, promotion of mental well-being. There's that continuum. We can talk about well-being and the importance and coping skills and just health promotion. And then also at the other end of the continuum where we need to think about intervention and treatment. So I am a proponent of more services in the school. I want to say one more thing about a word that we hadn't mentioned that we just need to say it out loud is parity. Or the lack thereof. President George W. Bush signed parity into law, and we still have not realized the true meaning of parity. So I always have to throw that out there. And I want to throw one more thing out that we heard this morning, and it's a normal human emotion of feeling guilt when our family members, our friends are struggling, or, of course, most tragically, die by suicide. And I urge anyone, because I would imagine that there's 0 degrees of separation between every person in this room and a family member or friend or ourselves who are struggling, is we have to let go. It's normal of the guilt and sort of blaming ourselves when either someone that we love tragically dies by suicide or experiencing other disorders. So I just wanted to put that out on the air, because I know that that is a common emotion, and we have to make sure that we don't blame others or blame ourselves. But back to your question, peds in schools, collaborative care with pediatricians, sort of figuring this all out, the Medicaid EPSDT program for early screening. All of those are critical when we're working with this, because the earlier you know, the earlier you can do something about it.
Absolutely. Yes, and Dr. Harris, I want to say thank you for that, because I think especially when, as you mentioned, we're hearing that folks themselves are having this guilt, having this anger, things of that nature, and all of that, if you're hanging on to that, can impact your own mental health. And so this is a conversation about not just those around us, but ourselves as well, and making sure that we are taking the steps that we need to preserve and take care of our own mental health. And on that topic, Daniel, I want to turn to you very quickly, because you've pointed out that Black men are very unlikely to seek mental health help. So 2 parts to this. 1, do we know why that is? And 2, what can be done to change this, to offer that help, assuming we have the access, the resources, all of the things that we talked about earlier?
Well, I think the first part of it, as a Black man that grew up in a family where my parents didn't know in terms of mental health, and my father is not unlike any other parent from the standpoint of telling my mom, "Oh, the boys will be fine," and telling us, "Shake it off." There was stigma with showing any kind of vulnerability in terms of anything that was happening with us physically or mentally. That hasn't necessarily change, but what is evolving is having young people and black men in different kinds of environments talk about their mental health and understanding their strength and vulnerability. And what we're doing is in trying to evolve that is we have an ambassador program where we're using young black men who have had different journeys. Like we have a couple of ambassadors that were NFL football players that retired before they were 30. These ambassadors are able to talk about their mental health journey. And through them talking about it and us leveraging their stories, we're helping a lot of men. The other thing that we're doing is we're trying to go upstream in terms of where can we reach them. We say at NAMI, nothing about us without us, and we want to make sure people are not alone. So we're trying to go into community through HBCUs, through the Divine Nine, which is sororities and fraternities. We know many black men are in fraternities, so we're trying to access and meet people where they are versus where we want them to be, and we know that we've got to go to them. The other thing is that we want to make sure that we promote reimagining crisis response for our community. What does reimagining crisis response look like? It looks like 988. It looks like 988. 988 is the new Lifeline mental health crisis line, as well National Suicide Prevention line. It used to be a 10-digit number. It's now 988. What's interesting is that if you go out to the different communities, it's only 2 years old. And that's another opportunity to actually make sure that the communities know, don't call 911, call 988. Just trying to make sure that we are speaking to the community. I'm speaking to my own family in terms of, and this is something that we hadn't talked about. So we're now having those conversations. And we just have to demystify mental health. We have to have the conversations and we have to meet people where they are. So we're very intentional in how we're doing that in terms of in the communities.
Yes, and I say very quickly, but I'm sure this is not a quick thing that we can answer. We have heard about stigma, and I think oftentimes there is this narrative that especially in communities of color, especially in the black community, that the stigma is more prevalent, that getting help, saying that you need or you're struggling is somehow embarrassing, that it's somehow something you should be ashamed of. Is that stigma still prevalent? Is that a narrative that is still happening today?
I would say that it is changing, but it's changing because of leadership. It's changing because of the trusted voices that are addressing it. If you think about, we talk about first responders, and a lot of times when we talk about first responders, we're thinking of medical emergency responders. We're talking about law enforcement, city police and sheriffs. If we think about it going back a while, first responders were our faith-based leaders. And what's happening is our faith-based leaders, which we are being very intentional in supporting them in communities, because that is where families and individuals are going for that trusted voice to talk about their mental health, to say, something's going on with my family member, what is it? So where the stigma is changing is in community where we're investing in the trusted voices of the leaders there. And it will take us going there. The other thing is in the workplace that Chris talked about. All of us work and in some capacity, and the private sector and the workforce in the private sector is critically important in terms of how do they operationalize reducing the stigma and actually talking about it in the workplace. The employee resource groups are important, the affinity groups. So what Amazon is doing, what Otsuka is doing is incredible in terms of empowering their workers and making sure that the workforce knows. Last thing I'll say is that if you think about it, young people that are coming to the workforce now, when you get to the part of the interview where you say, okay, what questions you have of me now after you've asked them a set of questions, they want to know about what mental health benefits are you providing? And they are selecting where they're going to work based off of the company that is making the investment, because remember what I said at the very beginning, people don't care how much you know until they know how much you care. And these young people want to make sure you care. Last thing I'll say is that, I know I said it before, I got to go there. We created something a few years ago called Next Generation. If you look at the demographic in this room, where are the young people coming behind us? So we created something 3 years ago called Next Generation. It was to bring 10 young adults to the table to work with NAMI to form and frame our work going forward. We put out a call to action and a process for 30 days for 10 young people to apply. We got 740 applications. Young people care about this. They want to be involved. So how do we create that force multiplier, that amplification of their voices? Because they want to do it with expediency. And that will help change this narrative about stigma.
Dr. Puckern, I want to come back to you. You're not off the hook over here. But we are in Washington, D.C. We're steps away from our Capitol, steps away from our White House. It's 2024. I don't know if y'all know this. There's a presidential election happening in November. And you have mentioned that you have real concerns about what could be at stake given the outcome of the election in November. Talk to us about that.
So first I'm going to put on my nonprofit hat, right? So no one can say that I am being partisan. But here's the point, right? Elections matter, and your voice is incredibly important. I was sitting with a group of patient advocates yesterday at a board meeting of the National Health Council, and there was a general agreement that we need voter registration. We need to make sure that people have the opportunity to vote. Because we're talking about systems, right? And I'm going back to the federal government. The fiduciary agents for the Medicare and Medicaid program are the members of Congress. CMS really responds to what the statute allows them to do. And so the course that gets set is set by members of Congress. I don't know how they operate. They don't have all the data. They don't have Daniel's data. They don't call him in every day. I know he's done some great work on the Affordable Care Act. But we have to build systems. If you really want to change mental health in America, it's about systems building. How do we know where to distribute our resources in community to make sure that we're touching the population that needs the help, right? And be it in school, be it in the workplace, be it clinically, those are system design problems. And in order to build those systems, we have to have members of Congress who get it, who don't sit around and want to have a debate about Medicare and Medicaid and whether we should cut it or not, or whether the Affordable Care Act should be gotten rid of. I mean, what are we talking about here? So what I would say to you is, make sure that in your community, people register to vote, even if they want to vote on the other side, that's good enough. But this is really a really important election. The future of America is now being defined. And I'll end with this. Benjamin Franklin said, you have a democracy if you can keep it. And so that is the question on the table in 2025.
I think that's such an important point, because I think when I go to the doctor, I don't know about y'all, I'm not sitting there thinking, what did Congress do to let me get here? Right? Like, I'm sitting there thinking, are you going to give me my medication? Is there something wrong with me? Am I okay? Am I dying? I'm not sitting there thinking about Congress. I'm not sitting there thinking about the president, but that's such an important
They're in the room. They are in the room. That doctor, and we've got a doctor here, and she can tell me if I'm wrong. Your insurance card says to the doctor, here's what I can give you. Here's how long I can give it to you. Here is the formulary that says you can't have it. That doctor doesn't tell you that, right? He doesn't tell you that I got to go back outside and look at that insurance card to see if I can actually write that script for you, or can I send you to the hospital, or can I even refer you to a psychiatrist? All of those decisions are made up there at Capitol Hill, even before it gets to the doctor. And that's my point. That's the systems building that is so incredibly important. So if you think your vote is not important and that money that's coming out of your paycheck to the $3.4 trillion isn't important, then don't vote. Don't vote.
Well, as we think about that paycheck, Chris, I want to come back to you with our employer perspective. How does Amazon normalize mental health? And again, thinking about our paychecks, where that money is going, thinking about, we have youth now who are asking, what's your mental health benefits for me? How is Amazon normalizing mental health?
Great question. And so to a large extent, as I showed earlier, it's having a range of options. So making it where there's an accessible point of entree for anyone who's looking for support for any issue, big or small. It's widening that aperture. So not only do you see the things that'll feel like familiar mental health services, so counseling, medication management, but also directly linked in with our financial well-being offerings, also linked in with our support for children and families. But beyond that we do in the benefits world, and it came through in a lot of the discussion today, is finding ways to create moments of connection and inspiration every single day among all of us. And so we have the Mental Health and Wellbeing Affinity Group. Dan mentioned the role of employee resource groups. We call them affinity groups at Amazon. Our Mental Health and Wellbeing Affinity Group is in many different countries, chapters all over the world. I am president emeritus of that group. And the coolest thing is to see how, just like Congresswoman McClain is describing, Congressman Torres is describing, it's saying hello to people. It is making sure no one is invisible in our workplace. It's making sure that at the very least you're going to get a greeting and some acknowledgement at the basic human level. A very micro example of this is on my team. The first interaction of every day needs to be good morning, or if I'm checking with my colleagues in the UK, good afternoon. Before we get to business, we're going to start with humanity. We're going to start with some acknowledgement of each other as humans. And that's not just a thing that matters to me in my heart as a person. There is loads of evidence showing this is a great idea, because it's not just your most important relationships that contribute to longevity and health outcomes. It's that diverse portfolio of relationships. So it's everything from your most important friendships, but it's also saying hello to the person at the coffee stand in the morning. It's greeting anyone you meet throughout the day. And so to bring it back to your question, there's all the epic things we're doing to build the future of mental health benefits. And all of us has an opportunity, even as we walk out of here today, to make sure that no one is invisible, and that we're constantly creating moments of connection and inspiration for one another as a powerful input to mental health.
Well, the four of you are definitely not invisible to me. Thank you so much to our panelists for such an important conversation. Appreciate all of you. Thank you so much.
Please welcome our final speaker this morning, Dr. Belina Shah, Senior Medical Advisor at the Center for Mental Health Services within SAMHSA, the Substance Abuse and Mental Health Services Administration.
Hello, Dr. Shah. How are you today?
Great. Good morning. So excited to be here.
Well, I'm so excited for our conversation. I want to start off, one of the words we have been tossing around a lot today is health equity, and this is something you are very passionate about, but I want us to take a moment. We haven't defined what we mean by health equity, so what do we mean when we use that term?
Sure, yeah, so when I think about this, I think about health equity, there's a classic slide or classic infographic where you have an individual, and there's three individuals, and they all want to see over the fence to get to a baseball game, or to see a baseball game. And health equality is where everyone has the same size stool, right? And everyone has that same size stool, but that means that if those three people are of different sizes or heights, that shortest person's still not going to be able to see over that fence. But when you have health equity, then you look at the individual person and say, what is it going to take to get you to see over that fence? And then you provide resources and allocate them in a way that makes sure that everybody can see over that fence together.
Yes. How are you helping keep that conversation alive?
Sure. So there are so many ways that we're doing this here through SAMHSA. So I work at SAMHSA within the Center for Mental Health Services, and I come. I know that Dr. Delphin Rittman, our Assistant Secretary, was unable to be here this morning, but would love to have been here. But at SAMHSA, we're doing so many things. Last week, we actually held a Black Youth Suicide Prevention Policy Academy. And a policy academy is where we bring states together. Sometimes we bring local communities. And when we look at these states and these local communities, and we have them bring together a cross-sector representation of who's there and help them to move towards finding solutions to a specific topic. And so we had a policy academy that's part of our Black Youth Suicide Prevention Initiative that I co-lead with Brandon Johnson. We also are infusing equity into everything we do. So we actually have a strategic plan, and in this strategic plan, that equity is one of our cross-cutting principles. And so as we think about how we we also are just help to release the National Suicide Strategy for Suicide Prevention, there's a whole strategic direction focused on equity.
Yes. There is efforts to develop local crisis systems in rural communities. Can you tell us a little bit about that and how that effort is going?
Sure. So I'm going to back up a little bit. I'm so glad that Daniel mentioned 988. So 988, this is the transition from the National Suicide Prevention Lifeline. It occurred about 2 years ago, just a second birthday last week. And it's a really exciting initiative, 988. There's been over 10 million calls since the transition. And what's really exciting about that is not only are there 10 million calls, and it's calls, texts, and chats. They're available in all three modalities, but that text and chat is really where we've seen the greatest increase. We've seen the greatest increase. It's an exponential increase, actually. And we know that our young people, our transitional age youth, our youth are more often using that text and chat feature of 988. And we really see 988 as a catalyst to develop an entire crisis system. And so we have relied on law enforcement too long to be the responders in our communities. And like we've said, this wouldn't have been appropriate with any other medical condition. And so when we think about 988 and we're developing out this crisis system, that we have these three main pillars. Someone to contact, and that would often be 988. But we do know that a lot of local communities and states still are using their old lines, especially as we work towards geo-routing. So really being able to better connect people to the closest 988 contact center. We also then have this second pillar of the way we think about the crisis continuum, and that's someone to respond. So that's mobile crisis, having people come into to you, and coming to someone coming to you, doing an assessment, triage, but then also helping to stabilize the problem to prevent you from going to the emergency room. I know that Daniel Dawes' work mentions a lot about the overutilization of the emergency room. We just heard about ED boarding and its impact. And so all of these things are to try to help prevent people from going to the emergency room. And then the last piece is a safe place for help. And a safe place for help can often include crisis stabilization centers, and to the highest fidelity of our current guidelines, it's almost like having an emergency room in the community. And and a psychiatric emergency room in the community. And what's so important is that this constellation of services can really help to keep people out of the emergency rooms, out of our somatic health emergency rooms, and really get them back into their communities, because we know that health, human community, and purpose are really the core foundational tenets of recovery, and that purpose often is employment, and that purpose of employment it feeds back into the numbers and the data that we showed today.
Absolutely. And on that topic of when we're thinking about the numbers and the financial numbers that we have heard mentioned multiple times, in your view, what's the cost of not making these investments into our underserved communities, whether that's communities of color or even rural communities? Sometimes they're impacted as well.
Yes, and I'm so glad you're bringing up the rural work. So we did a policy academy that was focused on rural communities. And when we think about underserved communities at SAMHSA, we do think about rural communities, racial and ethnic minorities, sexual orientation and gender identity minorities, just a diverse group of individuals and needs. And I even think about one of our grantees that they mentioned needing to build out their mobile crisis team. And when we were working with them to build out their mobile crisis team or discussing their mobile crisis team, they said, this is really important, but there's only one phone line on our reservation. Wow. There's one phone line left. And so, that may be our last phone line. And so when we think about equity and we really think about health equity in this behavioral health space, we really just need to think about centering at the margins and making sure that the people who are needing the most help and really needing that highest stool are really the services, is what we're developing our services for. Yeah.
When we think about the services that have been developed, I do want to ask, what have we seen from this current administration to prioritize minority mental health?
Sure. So I think I will also bring it back to not just 988, but CCBHCs, the Certified Community Behavioral Health Clinics. What's so exciting about the CCBHCs, which have been supported in a bipartisan fashion, is that they are really a really comprehensive clinic. And when you think about a comprehensive clinic that includes mental health care, substance use care, you think about also how primary care screening and monitoring and connecting back to that primary care, that this is a really, really important model. And there's several elements of CCBHCs, and they're paid for in multiple different complicated ways that we clearly don't have time for. But one of the really impactful things is that there's been in the Bipartisan Safer Communities Act an expansion of the Medicaid demonstration programs. And the Medicaid demonstration states, they really can look at all that it takes to provide those 9 required services as part of the CCBHC. So there's multiple services, including crisis services. And then they pay for that at cost at the state level, and they enter an agreement with CMS. And I really think about investment. And when you think about the word investment, when you invest in your portfolio, a statement of privilege, right? When you invest in your portfolio, that you know that sometimes there might be a drop, right? There might be a loss. And in an investment, you're going to see that grow over time. And so when the CCBHCs, I love this model so much because it includes our crisis care, it includes all that we need, and it finds a way to provide that glue to make sure that people are getting all of the care that they need in that health home community and purpose in an equitable fashion. So that's one of, and within the CCBHC criteria, there is a requirement that there is data disaggregation, that there is stratification, that there is community outreach and engagement, that there are people with lived experience being on the advisory boards of these organizations. So we think about this and all the work that we do in many ways. Yes.
You mentioned the bipartisan work that is on for this topic, and we've heard this mentioned multiple times today. What is it about mental health that you think drives bipartisanship in such a time where I think we can all admit it's a fairly polarized political time out there?
Yes, I think there's many elements. I think number one, that we have seen behavioral health concerns really be a driver of our decrease in life expectancy, in the last several years, and we've been bouncing back, and COVID has created an overlay to that. But just the fact that with the advances that we have, to have any decrease in life expectancy is really concerning. And so we know that there's a significant risk of mortality, and also a risk of morbidity. And when we think about, once again, those dimensions of health, home, community, and purpose, that really, when somebody is well, that they can contribute to them. That's the fabric of society. I mean, I even just think about, I was walking through a drugstore the other day, and I saw someone, and she looked displeased. She just looked unhappy. She was restocking a shelf. She didn't have a need to interact with me. But I thought about, everyone's saying the service is not that great. We tip for everything now, even if we didn't interact with anyone, right? But if you think about it, how can you provide that bubbly, chipper service when we know that the rates of depression and anxiety are increasing? How do we, when we interact with someone, you're giving of yourself more when you know that you are internally struggling? So I think that when we think about mental health, we know it really underpins the fabric of our society, behavioral health broadly.
Yes, absolutely. And I think that's such an important point, is when we're struggling, and maybe it's from factors in our life, it's like a continuation. It's a circle, and then especially if you have to go to work and you have people at work, especially if you're in the service industry, who are annoyed because we have to tip again, and we're like, well, you didn't do anything for me, et cetera, et cetera. So I know that's something that's come up often today, is just about our interactions with other people. And so to close out, Dr. Shaw, I want to end on a little bit of a hopeful note. What is encouraging you, or what do you feel encouraged about the road ahead?
So there are many things, so many things. So I've already mentioned 988 and the CCBHCs. Some of the other developments in the crisis continuum space is that we are working together with a subject matter expert group to help codify the definitions of what the crisis services are, so that we can continue to work with payers, and payers are part of these experts, to think about ways to spread not just the accountability and responsibility, as well as the benefits of a well-funded crisis system. And so there's some work that's going underway to really think about growing and sustaining the system, that's very important. I mean, we have grant funds like the mental health block grant, and it's set aside that's required for crisis care, but that really isn't going to cover the breadth of society that we need. I'm really also excited about the CCBHC expansion. The beautiful thing about CCBHCs, just like the rural crisis mapping work, is that each community, each state can help to develop the elements that are required to serve their unique communities. And that is really informed by the community itself. So that's one of my last statements of hope, is that I'm really excited and encouraged that we are engaging communities in this work. And communities are everyone. We've heard, I think the presenters here over the course of the day are representations of the multiple sectors plus more. Last week had that was part of the Black Youth Suicide Prevention Policy Academy, and just hearing youth, we had a youth panel, just hearing youth talk so openly about mental health, that the stigma is not there for them like their parents and other generations. And just seeing them speak so openly mental health and also providing solutions, which was very exciting. And just thinking about wholeness and wellness, and not just thinking about the absence of disease, but really thinking about how do we build healthy communities. It was just so impactful. But seeing also their leadership, I was moved to tears. And I really think that engaging communities, engaging people who are receiving services, and helping them to become part of the provider community, and also thinking about faith-based, all of these other sectors, I think is just so important and so exciting to me that we are doing this as a partnership. The federal government can't do this alone. If we would have, it would have happened a long time ago, yes. Right? So we have to work together, and that's my most exciting. Some of the things I'm most hopeful for. I will also just say that I'm excited about 988. Just in itself, and there are also some other resources like findtreatment.org, findsupport.org that we have, and they're also translated into Spanish as well.
Absolutely. So we have a lot of work to do, but we have made progress. I think one of our guests earlier said we have made progress. We have not reached victory, but there's so much for us to be hopeful and encouraged by. So Dr. Shaw, thank you so much for joining us today. Thank you all. Appreciate all of you.
I'd like to thank Dr. Shaw and Cheyenne. That concludes our program for today. I'd like to thank all of our amazing speakers. I think we had a really important and great discussion today. I'd also like to thank our sponsor, Otska. And on behalf of Otska and The Hill, we'd like to thank all of you for being here today in person and online. If you missed any part of this, you'd like to see it, the whole event will be on The Hill. And those who would like the Meharry report we talked about, there are physical copies on your way out. So thank you very much.